Yeah, thank you, Chairperson. I'm going to talk on deep brain stimulation, choosing the right patient and choosing the right target. So, for all those students who are sitting there, what is the deep brain stimulation? We place the electrodes within the certain areas of the brain. These electrodes produce the electric impulse that normalize the abnormal circuitries in the brain. The electric impulses also affect the cells of the brain and the chemicals within the brain. How do we give the correct amount of stimulation? We place a pacemaker like device under the skin in the upper chest, and a wire connects this device to the electrodes in the brain, and stimulation adjustment is done by an external remote device. Which are the commonest brain nuclei that we target? So, ventral intermediate nucleus of the thalamus, we usually use to reduce the tremors. Subthalamic nucleus and globus pallidus interna, we use to treat the Parkinsonian symptoms. So, both these nuclei not only reduce the tremor, but they also decrease the bradykinesia, rigidity, gait impairment that plague the people with Parkinson's disease. We use DBS to treat various other movement disorders such as dystonia, tics, and variety of other neurological disorders such as pain, depression, and OCD. And this is a schematic representation of the deep brain stimulation implant. Now, coming to the talk, who benefits from this procedure? The patients with movement disorders in whom we are not able to control them adequately with the medical treatment. The oral medications of dystonia and essential tremor, if you go over them, they are not disease specific. They have variable efficacy and they produce intolerable side effects in significant proportion of these patients. We are not able to really control the symptoms of dystonia and essential tremors. PD medications initially have an honeymoon period, but as the disease progresses, we start seeing the dose-related fluctuations, and these are the patients we subject to the deep brain stimulation surgery. So why do the stimulation? Why not the good old lesioning, which is cheap? So we started doing the lesioning initially, and then we realized that the effect of the lesioning lasts only for a few years. It doesn't last for long. So we went ahead and made bigger lesions and bigger lesions. And then ultimately there wasn't much left to do it. And the patient still had the symptoms. So this was a problem with the ablative surgery. And that's the reason we switched the gear and started using the deep brain stimulation. The first deep brain stimulation actually was reported from Germany's 1977 by Mundinger. He was the one who actually used it for spasmodic torticollis. He stimulated the motor thalamic nuclei, VOA and VOI, and subthalamic zona incerta, as well as pyramidal tracts H1 and H2. And he found a significant benefit in the spasmodic torticollis. But the real pioneering work was done by Benabit, a French neurosurgeon in 1991. He was the one who first reported the efficacy of WIM stimulation with implantable pulse generators. And subsequently, there were many single and multiple center studies reported substantial benefit of essential tremors with WIM stimulation. And this led to widespread use of DBS all over the world. How does it work? How does the DBS work? So this is a very basic model of the basal ganglia. So we have a direct pathway and indirect pathway. Direct is facilitatory and indirect is inhibitory. So if you see the indirect pathway, the subthalamic nucleus and globus pallidus internus exert an inhibitory influence on thalamocortical motor pathway. So they inhibit the motor when there is an excessive firing of subthalamic nucleus. This excessive firing of subthalamic nucleus is responsible for Parkinsonian symptoms of producing akinesia. So the minute you inhibit subthalamic nucleus with deep brain stimulation, you get the relief from the akinesia. This is putting it very simply. How does it work? With the same model in dystonia, which is a hyperkinetic disorder, and we are using the same nucleus, globus pallidus internus. In hyperkinesia, there is an imbalance between the direct and the indirect pathway. So that is the surround inhibition concept gets lost in dystonia and hyperkinetic disorder. And DBS help us normalize this abnormal circuitry which has gone or in the hyperkinetic disorder. These are the simple target sites for the DBS therapy: WIM thalamus for essential tremor, subthalamic nucleus for Parkinson's disease as well as dystonia, and globus pallidus interna for again Parkinson's disease and dystonia. So let me come to DBS in Parkinson's disease. So initially we started with thalamic stimulation in WIM nucleus, but this only controls the PD tremor, remember. It doesn't control the bradykinesia and rigidity. So if the person has a very severe Parkinsonian tremor, we can use the WIM nucleus, but we now use the thalamotomy rather than using the thalamic deep brain stimulation in Parkinson's. Now we have two nuclei in Parkinson's. One is a pallidal nucleus. So stimulation of the pallidal nucleus helps all the major motor symptoms of the PD, including dopamine dyskinesia. So when you stimulate pallidum, you actually reduce the dyskinesias and you reduce the involuntary movements associated with the drugs. It also helps reduce the painful cramps and sensory symptoms in off stays. But GPI stimulation does not help in reduction of the PD medication. So that's why if you have drug-induced side effects in Parkinson's patients such as orthostasis, psychosis, daytime lethargy, cognitive impairment, then you're not going to choose global pallidus synthesis. You're going to resort to STN stimulation. So STN stimulation provides a similar improvement in the motor symptoms, but it improves gait, tremor, and bradykinesia, and it allows a reduction in the PD medication, leading to fewer drug-induced adverse events. Then we have an additional nucleus in Parkinson's, which is now making the sensations, particularly in the advanced PD, that is PPN nucleus stimulation. So I have two controversial papers. The first one was by Lozano and Elena Moro's group, which showed that unilateral PPN stimulation improves falls in Parkinson's disease. So when they did this study, they did not improve UPDRS3. The only factors that improved in UPDRS3 with this PPN stimulation was freezing and the falls. But subsequent study by Tom Fontaines and Patricia Limousin's group showed that PPN did not improve the gait freezing as well as the falls. PPN is still in the questionable stage in the advanced Parkinson's disease. How do we select the patients? So the standard selection criteria, PD should be at least 5 years of disease. Why? Because then we don't do it on the atypical Parkinsonism. By then, the atypical Parkinsonism would significantly worsen, would become wheelchair bound, or would be bed bound. UPDRS3 off score should be more than 30, and Hone and Yan score should be less than 4. Significant response to levodopa. This is very important. The patient should have 50% reduction in the UPDRS after a single dose of levodopa, single correct dose of levodopa. Patient should have normal cognition and no major psychiatric manifestation. And if there is an impairment of normal function in spite of the optimal therapy. If the patient has a lot of motor fluctuation, they have troublesome dyskinesias, they are ideal for undergoing the DBS. Disabling medication refractory tremor is another indication, and marked medication intolerance, that means you give low dose dopa, it still causes dyskinesia, psychosis, and orthostatic hypotension as well. In 2012, these guidelines also said the same thing, that you should do the DBS for PD if they're resistant to medical therapies, which is not completely correct. They have severe medication side effects, that means on and off fluctuations and lengthening of the off periods, but are medically and psychologically fit for surgery. This is a very good slide, and I'm going to take you through this slide. So we have three groups, okay? We have a young onset, which is what we commonly see in India. Then we have a middle age onset. That means the lower, if you see the lower graph, this is a young onset. That means the disease began at the age of 45. This is at the 55, and this is when the disease began somewhere in the late 60s. So in the young onset, you have this honeymoon period when the drugs are working beautifully. You don't have any off periods, you don't have any fluctuations. But then the honeymoon period ends, and then you start having the motor fluctuation. Then comes the symptoms as the disease progresses. These are levodopa-resistant axial symptoms, speech disturbances, cognitive decline, and these do not respond to DBS. You must remember that. So there's no point in sending the patient to DBS when you are seeing these patients. A lot of our neurologists think that they should send the DBS when they are advanced, when they are falling, when they have cognitive decline. That is the correct time. It's not true, because DBS is not going to improve that. DBS only improves what levodopa improves. So if you have levodopa responsiveness, DBS is going to do exactly that. If you look at the middle age onset, this thing, he has a honeymoon period, but this particular period is significantly less. So you have a window of opportunity which is only for roughly 10 years, as opposed to the young onset. And then the actual symptoms come. Whereas late onset Parkinson's disease, when you start seeing Parkinsonian symptoms at the late onset, you're going to jump from the honeymoon period to the bad period of actual symptoms and this thing. So that's why it's important that you send the younger patients for the DBS earlier than before they start developing the actual symptoms, before they start developing the symptoms which do not respond to levodopa. It's the same thing with middle age onset. And in the older, your window of opportunity is very narrow. So if you're going to think of DBS in the older patient, do it when they have normal cognition, not when they're falling and when their cognition is faltering. So don't miss that window of opportunity. This is where you have to send the DBS patients for the Parkinson's disease. So what are the results of this early STEM trial, where they did it within, after the 5 years, when the on and off fluctuations just started? They had early motor complication. Mean age of onset was 52. Mean duration of disease was only 7.5 years. Randomized to undergo neurostimulation plus medical therapy and medical therapy alone. This is a landmark trial. So what was the result? At the end of 2 years, PDQ 39 score improved by 26% in the DBS versus the best medical treatment, where in fact there was worsening by 2%. UPDS's 3 score, that is a motor score, improved by 53%, and in fact only 4% in the BMT. That means there's no doubt the earlier you go, the better you are. And the medication doses were reduced to 39% in the stimulation group, but increased to 21% in the best medical management. The cost utility also showed that definitely quality adjusted life year gain was much more. That means you are going to keep these patients working and mobile. So the direct cost of medicine we are not comparing. We are comparing what the patient can do if you do the DBS early into the disease, showing that ST and DBS at the earliest stage of the disease is cost effective in the patients below the age of 61. What about still earlier? Should we go a little earlier before the fluctuation starts? So 30 patients with idiopathic PD, ages between 50 to 75, were on medication just for about 6 months, but had less than 4 years of the Parkinson's disease, and they didn't have motor fluctuations or dyskinesia. They were randomized. Again, mean UPDRS total part 3 scores were similar at 24 months. The DBS group took less medication at all time points, and this reached maximum difference in 18 months. So 2 patients had serious adverse effect. So I don't think it was really great result when you went a bit early. So again, early versus late stimulation may optimize functioning and improve the quality of life earlier. So before these young working people lose their life to the fluctuations, significantly disabling off periods, significantly disabling dyskinesias, you need to go in and do the DBS on these patients. So patients earlier in the disease are younger, and they may be able to tolerate the surgery better with the fewer side effects. And there is a possibility of neuroprotective role, which is still not proven. So this is the young patient I had seen. His disease began at the age of 26, and you can see how bad he is. Akinetic, has severe disabling tremors, and he was very embarrassed because he was a hotel receptionist and he couldn't maintain his job. And this is after the DBS. I just wrote to him yesterday because I couldn't find his post-op video. So he sent me the video. He still maintains at the end of 7 years a good response to the DBS. So this is where we place the electrode. This is the red nucleus. If you see here, this is the red nucleus, and it is onto the lateral aspect of the red nucleus. You can see the STN. This is slightly laterally placed, and this is the programming that we do. If you see, one of the electrode is slightly laterally placed, and this can have a devastating effect if you are 1 millimeter here and there. What about dystonia? Stereotactic ablation of the globus pallidus or thalamus had been used for many, many years to treat the medically refractory generalized dystonia. This goes even 50 years ago. Early reports of DBS for dystonia involved thalamus and globus pallidus internal segment. With the increasing success of pallidotomy in DYT1 mutation, the globus pallidus became the primary target for the primary, and now we call them isolated dystonia, but the thalamic target is also used by some. What are the other targets that we use in dystonia? We use subthalamic nucleus, we use thalamus, and we use cerebellum also. What about the studies evaluating 14 patients with GPI DBS and 16 patients with ST and UBS? There should be always a debate between Rupam and I about whether should we do GPI for the dystonia or should we do the STN for the dystonia. They found that GPI was much better in alleviating actual symptoms, 93 versus the 83% in the BFMDRS. On the other hand, STN uses less battery, so replacement of the battery was less. But now with the newer batteries, which are lifelong, we don't have to worry about the battery consumption. WIM DBS has also been described in the patients with dystonic tremor. Earlier, the boundary between the essential tremor and dystonic tremor was so faint that I think a lot of essential tremor were dystonic tremor and were subject to the WIM stimulation. Recently, deep anterior cerebellar, there's a new significant role of cerebellum in dystonia. So deep anterior cerebellar lobe of DBS has been used with some success in the patients with cerebral palsy associated spastic dystonia. We usually avoid cerebral palsy associated dystonia because they don't respond as well as isolated monogenic dystonia. So how do we select the patient? Most important factor in dystonia is clear diagnosis of the dystonia should be established, like Kailash had yesterday shown what is dystonia. Age of onset is very important, duration of symptoms is very important, and lack of serious comorbidities. Whether the movements are fixed, if the movements are fixed, they are less likely to improve with the DBS. If there is a mobile dystonia or a phasic dystonia, it's likely to show more and more improvement after the DBS. And DBS in dystonia takes about 6 months to show the real good improvement. So you will not see the immediate improvement like you see in Parkinson's disease. It will take about 6 months for it to show the improvement. We know that the outcomes are a little better in isolated dystonia than the other types of dystonia. So if there is an isolated dystonia and it is disabling and it is medically refractory, particularly it is not dopamine responsive dystonia, then we definitely consider DBS very early. And this is the patient. Actually, this is a very interesting patient. She used to take botulinum toxin injections for her cervical dystonia. Then she went to United States of America. And when she came back, she had a camptocormia. And if you carefully see, she has a flexion of the legs and she tends to bend forward. And she's been injected with botulinum toxin in USA. That's why her neck is straight. And she had, from neck dystonia, progressed to the generalized dystonia. So we did her surgery. And after the surgery, because it had progressed to the generalized dystonia, I sent her genetic testing. And she turned out to be genal mutation. We published it, this thing. So besides DYT1, now we realize that genal mutation and DYT6 mutations respond very well to the DBS. So you should not miss sending these patients for the DBS surgery. In fact, genal does sometimes better than DYT1 on the long-term effect of the DBS. DYT6 has a variable effect. Sometimes it really responds well, but the long-term effects are not so great. So this is the DYT1 dystonia, which Dr. Sankhala had seen in Iran. Videos were seen by me. And she was positive for DYT toxin A, DYT1 dystonia, and see how she is post-DBS. So that's why you shouldn't miss choosing these patients and sending them at the right time before they develop contractures or before they develop the fixed deformities on their dystonia. So coming back to the DYT6, very prominent neck dystonia, upper limb dystonia. I'm going to just move this forward a little bit. You can see him walk. So this was a salesman. He had to stop his job because of, and this is the post-operative. So he responded to DBS for good 12 to 15 years and then he died of a myocardial infarct. So another dystonia that responds to DBS is DYT KMT2B, just few seconds. And this is again very prominent. He had isolated dystonia, but this is again isolated and combined, again a monogenic dystonia, and they respond very well to the DBS. We didn't do the DBS on this child. We are waiting for him to grow up a little bit. So DBS is considered most effective in childhood onset monogenic dystonias. That is DYT TOR1A, myoclonus dystonia syndrome, DYT THAP1, which I showed you, KMT2B, DYT HPCA, which is an autosomal recessive dystonia, DYT 2, and DYT PERCRA, which is DYT 16. They respond very well to this thing. And yesterday, Dr. Bhatia told you about adult onset focal dystonia. So we have DYT GNAL and DYT ANO3, and they also respond very well to this thing. What about the other dystonia? So atypical PD, you can see how bad she is. She went to Mohit subsequently, and she had a tongue dystonia, and he had to amputate her tongue because it had completely become gangrenous. So she is a adult onset PCAN, and post DBS, she did very well. Okay, with good sustained. So coming the last slide on the DBS in tremors, we have different nuclei for the tremors, but the most commonly used is a WIM. Now we have a new one, posterior subthalamic area zona incerta. And this is, I borrowed from Dr. Jackie Ganguly. So this is his right hand. I'll go to the left hand. You can take support. See how bad he is. Okay. And this is post DBS. He's able to actually use the hand very well. Okay. All right. So this is how it is. So comparing between the PSA and WIM, there is no difference between the two sides. They found they have equal improvement in the tremors, in the essential tremors predominantly. And then zona incerta also is an alternative target for the ET-DBS. But then comparing with the WIM-DBS, the WIM-DBS provided better tremor suppression. What about Parkinson's tremor? Subthalamic nuclear stimulation, which I showed you in the earlier patient, controls the Parkinsonian tremors also very well. Word of caution, I showed you all the good videos, but there are a lot of complications associated with DBS. If you go even 2 millimeters wrong in the STN, you can have a devastating side effects or have no benefit, or you'll have asymmetry. And this is how I feel when I'm sending the patient for the DBS. So be careful. Correct selection of the patient, correct selection of the target is extremely important in doing the deep brain stimulation surgery. Thank you.